Yes, sir.
Yeah. Well, osteoporosis is a pretty old topic for us because if you just look at this illustration.
Make it a full screen. Go to the lower icons and.
It is fine.
8.5.
Oh God, now what's up? Doing okay.
Sir, the peg-shaped button on the bottom.
I'm sorry?
The peg-shaped icon at the bottom. Come to the bottom. Yeah, yes, sir. Yes, this one. Yeah, thank you.
Okay.
Yes, sir. Thank you, sir.
Well, this is a picture from Thakurmar Jhuli. And you can see the queen has got hard Marmari Ashuk, which is basically osteoporosis. And there is a serpent, is a Rakhosh going over her. So it is something that is not unknown to us and to our literature and to our people. Now, osteoporosis is, of course, a skeletal disorder, and you can see the difference between normal bone, which has a very tight matrix, compared to an osteoporotic bone, where the matrix is fragmented. And if you look at an illustration like this, see on the table on the left has only got straight legs. Now, if you put a heavy weight on that, it'll collapse. But if you have a table with cross struts, like the table on the right, then that can take a heavier weight. And that is exactly what happens with the normal bone versus an osteoporotic bone. Now, osteoporosis is just one factor in fractures. It's not the only cause of fractures. In a study, there are many studies like this. About half of the hip fractures were in women with normal bones. In another study, about 40% of hip fractures were in women with osteoporosis. However, if an osteoporotic person has a fracture, then the outlook is much worse, and it can actually be lethal. So, bone strength is not complete, is not equal to osteoporosis. It depends on bone quality and bone density. Now, if you look at bone mass, this is how, as a child, the bone mass goes up and up, and then in the 30s, early 30s or late 20s, peak bone mass is reached. After that, bone mass starts to decrease. The red line is the female bone mass, which decreases abruptly at menopause. And our T-scores are based on the peak bone mass, which is sex-related. And we look at the bone mass of the subject compared to the standard peak bone mass and see what is the standard deviation by which it differs from the peak bone mass. And that is exactly what we do with the Z-score, which looks at age-matched controls, and T-score, which is more commonly used, which looks at peak bone mass. And you know very well that severe osteoporosis means that the T-score is more than minus 2.5. Now, calcium and vitamin D, which was discussed in the slide, actually is not so simple as one intuitively feels. Now, calcium supplements are absorbed variably. For example, a standard calcium carbonate tablet contains 1200 milligrams of calcium, and about 500 milligrams are available for absorption if taken with a meal where hydrochloric acid is there in the stomach. Now, there is a marginal increase in bone density, and there has been no study that shows it has a direct effect on falls or fractures. It's more intuition than actual data. There may be an adverse cardiovascular impact. Regarding vitamin C, it's a good thing to have, but it doesn't seem to affect fractures, but does improve falls when you have less falls. There's some data on cardiovascular risk. I share that with you, cardiovascular risk and calcium. The busy slide, I'm sorry. Top is myocardial infarction hazard ratio. The blue line is with calcium supplements. The dotted line is with placebo. The middle one is the stroke. Again, blue line is calcium supplements and red line is placebo. Same with the cumulative incidence of both stroke and myocardial infarction. So there does seem to be an adverse cardiovascular signal. Not very much, not very big, not very prominent, but basically the message will be that there is some cost to pay for having good bone health with calcium, just as with aspirin, you pay a cost when you're having aspirin for cardiovascular problems, but except the GI bleed and the brain hemorrhages. Anyway, why is osteoporosis serious? This is actually what we have to know. If you look at the middle part of the slide, osteoporosis kills by its complications. It affects more women than heart attack, stroke, and breast cancer put together. It compromises the quality of life, and the fractures it produces are extremely expensive to treat. In India, over 5 lakh women over 60 have a fractured spine. Over 2.5 lakh Indians suffer osteoporotic hip fractures every year. Most of these fractures are never investigated for osteoporosis and never, therefore, is the cause treated. So here we have, this is a little old data, but we have 5 crore osteoporotic patients, 1 crore patients with fractures, 65 firms marketing anti-osteoporotic drugs. There are 172 brands of bisphosphonates. However, only 0.23% of patients receive treatment, and typical duration of treatment is just 3 months. Now, biochemical markers that was commented on. We have 2 types of markers. Markers of bone formation on the left, of which the prototype marker is P1NP or PINP as it is commonly called. So the higher the PINP, the better, which means you're having better bone formation. Now, if the bone is resorbed, then in the urine, you have excess of the resorption markers, typically CTX and NTX, which are the terminal collagens of the telepeptides in bone. And if you have a low resorption marker, that means less resorption. High resorption marker means that the bone is being eaten away. Now, this is an interesting case. This lady I had seen, she had surgery, pituitary surgery together with radiotherapy in South India in 1999. DEXA spine was minus 4.1, and since then she has been on bisphosphonate from 1999 to 2009, that is 10 years. Then she had an atypical femoral fracture like this, which is typical of overuse of bisphosphonate. And then she came to me in 2014 on a wheelchair after having another fracture, typical like this one. And then that was my first and last consultation for this lady, because she got very upset when I told her that you have to stop the bisphosphonate. However, this is a problem with bisphosphonate, because if you stop the resorption, what is happening is that you are having old bone around, which is not very strong. And the continuous remodeling of bone is inhibited. So new firm bone is less and old, not so firm bone predominates. It doesn't show on the DEXA, but the quality is compromised, which is why you get these fractures. And which is why there is a fixed duration of treatment for bisphosphonates. And therefore, there is this question of when we should restart treatment or drug holiday, resumption. Now, who would benefit from a drug holiday? This is an interesting slide. So you just ask these questions. How long have you been on treatment? More than 5 years? Was your fracture risk high, medium, or low when you started? What is your fracture risk now? What is your bone density? Have you had a fracture? And should you take a holiday? Well, if you have a load on the left, green, if your fracture risk was low, if your bone density is okay, you've not had a fracture, then you can take a drug holiday. On the right, you have been on treatment for more than 5 years. However, your fracture risk was high, it is still high, and you have broken a bone, then maybe you should not take a holiday. But this is just one piece of information. There is a lot of information to suggest that you should not persist with bisphosphonates. But after a course of bisphosphonates, which varies depending on the drug used, 3 years for zoledronic acid, about 5 years for alendronate. Anyway, but holiday does not mean that treatment has to stop. And a second fracture has to be prevented at all costs. And any fracture except skull bone fracture counts as a fracture. Any fracture in the mother when she was over 50 years old increases the risk. Weight under 57 kilos, smoking, and if you need your arms to get up from a chair, that is a risk. So if you're in a sort of risky category, and there are many other engines, including the FRAC score for looking at risk. If you're in a risk category, then of course no holiday. And if you are in a low risk category, then yeah, a holiday is appropriate. In this particular lady, I would advise either teriparatide because the PTH is normal, or denosumab. The problem with denosumab is that if you stop it, your fracture risk accelerates dramatically. So basically you have to have it permanently, but it's just 2 subcut injections a year. A repeat course of zoledronic acid has its supporters and opponents. It is an option, but after, I would say, some years have passed by, we do not know how many years, but maybe in this lady it would be an appropriate option. Vitamin D supplements are necessary because most of us are vitamin D deficient. We don't know exactly how, we cannot prove the good it does, but one thing is for sure that if you have osteomalacia or low vitamin D, then the DEXA scans will give misleadingly low values, and you will mistake a vitamin D deficient osteomalacia for osteoporosis on the DEXA. Repeating bisphosphonates, with no clear data, as I said, hence no consensus. The bone contains the drug for a long time, at least 5 years, and after 10 years, 25% of the drug is still retained in the bone. There are side effect concerns, including esophagitis, some cases of esophageal cancer, some cases of atrial fibrillation, and some cases of osteonecrosis of the jaw. These are very rare. These are not really mainstream, but the data is there and the patients can read it on the net. So as I said, in this particular person, teriparatide or denosumab would be better options. Take homes. Well, must prevent a second fracture. If the patient is under your treatment and there is a second fracture, it is a disaster. So what do? Osteoporosis drugs, muscle strengthening exercise, because we really want to prevent a fracture. We just don't want to treat the DEXA. Exercise, better shoes. You see at the bottom, shoes where you have a back support or a support at the ankle. Check for rhombergism. Avoid postural hypotension. Check for postural hypotension and avoid drugs that actually increase the risk of falls. Particularly common example is chlorperazine, which is often given, I think, inappropriately for dizziness or vertigo. And so you avoid these drugs, but there is some data to show that even if you avoid fall-producing drugs, you may not prevent falls. But however, I don't think we should give them inappropriately. So this is the basic take-home, and thank you very much.